you, sir. Thank you, sir. I think it's all for love of nephropathology that we are doing all this. And I hope I'll be able to deliver the way I should be doing it. So, in the meantime, I share my screen, and here it goes like this. So, I'll try to remain very basic, and I would appreciate anytime anybody wants to kind of want me to stop or there's any query, we can kind of keep resolving them while we are proceeding. So please don't hesitate to stop me or to ask any question on the way, right? So while we start interpreting a renal biopsy, what is the first thing I look at is the clinical scenario, because I'm supposed to answer the clinical question which is there on the form. If the form asks me an answer for a nephrotic syndrome, my interpretation would depend upon what was the clinical scenario. If it needs an answer for hematuria, then I need to do some special tests and something more to come up to the diagnosis. So clinical context becomes very important, and that is why we keep requesting our clinical colleague nephrologists to give us as much information as possible, because it really helps us. Then interpretation of kidney biopsy by no means mean only light microscopy. Short of immunofluorescence and light microscopy, it becomes very difficult to understand the pathology, which you'll be able to understand once we go through the slides. EM is does refine our biopsy diagnosis. In some situation, it is really kind of diagnostic, but at least light microscopy and immunofluorescence is something which we really want to use for a routine diagnostics, and we do it routinely. So when we are interpreting a kidney biopsy, in every case, we try to give you information on four parameters. One is the glomerulus, tubular interstitium, and vessels. And we make a deliberate effort every time to give this information, because they are interrelated. But to come to the point that this is mainly a glomerular pathology or a tubular interstitial or vascular, that is the first hunch we take out from the low power magnification of our interpretation, right? So light microscopy is the starting point after having seen the clinical scenario. um, uh, uh, so in our attempt to give you a diagnosis, we not only try to give you only the diagnosis, but there are some clues for prognostication also in the biopsy itself. So in our report, you would find some degree, some element of reports would indicate whether this patient is likely to progress, or can, whether it can revert back or not. So this information would be available from our diagnosis. And this again, as I mentioned in this green color, that means our biopsy can have one diagnosis, multiple diagnoses, depending upon the clinical scenario. If my biopsy shows me a normal morphology and has a nephrotic syndrome, I will bring in podocytopathy. If I'm talking of lupus class 2, but still patient had very significant proteinuria in the clinical context, when I see investigation, I think that I need to add one more parameter of podocytopathy to the lupus class 2 or something like that. So what I mean to say is, all my, whether I give one diagnosis or two diagnoses, would depend upon what has been the clinical scenario as far as the patient was concerned. And these terminologies, I'm pretty sure all of you must be aware of, like whether the patient has a nephrotic syndrome, nephritic, or is it asymptomatic hematuria or proteinuria. So our interpretation and our last lines depends upon what has been the clinical scenario. Similarly, rapidly progressive renal failure, the most common, as we understand, everybody would jump onto crescentic, but there would be many other causes, including drug-induced injuries, which can present with RPRF. So the clinic, this is just to again re-emphasize the point that the clinical scenario is the one which becomes very important for us. Another feature which you see, these all parameters are available on our form because they help us in interpretation. Because a 24-hour proteinuria, if very heavy, I try to bring in an element of collapse. I try to do serials for looking up for collapse. If my proteinuria is in the range of 4 to 6, maybe I may not do that exercise of doing multiple serials to give out the answer. Similarly, for example, I see a kidney size being large, 10 to 12 centimeter, and patients had a rapidly progressive renal failure. So that gives me a clue that maybe this patient might be having, again, collapsing glomerulopathy. So there is always some clue in the clinical scenario, as well as investigations which you provide to us, which helps us in giving you the final diagnosis. These are a list of syndromes which present as nephrotic syndrome in about 50% of the native renal biopsies. This data is from University of North Carolina. So I'm not going to read out all, but this is just to emphasize the point that same clinical scenario of nephrotic syndrome can have this kind of a diverse diagnosis. So, and as you see, all of them would encompass the utility of immunofluorescence in distinguishing these. They could have, see, kidney has very limited way of reacting, and what it is reacting to, that we get that information we get from immunofluorescence, right? So the combination of light microscopy and immunofluorescence makes the diagnosis. And same clinical scenarios we see, there are more than 15 causes which could result in similar morphological features. Similarly, for as you see on this slide, hematuria or nephritic presentation. So all these situations, all these conditions would present with nephritic presentation or maybe hematuria. But as you see, we need to distinguish them based upon our kidney biopsy interpretation. As you see here, even Alport syndrome, where your light microscopy and immunofluorescence are going to be negative. So in these scenarios, need to go on to the electron microscopy. So this doesn't mean that we won't do EM in all these cases, but these are the situations where you really need it for diagnosis. So in such situations, you can take out tissue from even from the your kidney biopsy tissue submitted for light microscopy also, if you don't have provision for separate EM core available, if the facilities are not available. Similarly, there are situations about 5% of the biopsies, native biopsies present with only acute renal failure without an element of proteinuria. So these are the situations, as you see, which can present with acute renal failure, which range from purely being vascular pathology to being interstitial pathology. And in some, and here, as you say, see light chain cast nephropathy, that means even your immunofluorescence is helping us coming to the diagnosis. So this was just about some what are the clinical situations where it becomes important for us for interpretation. Now, just going by morphology, I'll go very slow on this. So as you see, this is PA stain uh, section, and I'm showing you this round thing is the glomerulus. And within the glomerulus, an arteriole enters from one side, which we call hilum, and this capillary, this is a capillary, then it divides into multiple lobules. To keep these capillaries bound together, what we have this pink material, what we call mesangium. This is something which holds them together. Otherwise, they are going to be a one single loop. So this mesangial matrix is formed by mesangial cells. These cells are mesangial cells, which are seen in the pink material. So this, normally we would like to have only 3 nuclei here, that is normal mesangium. This is the glomerular basement membrane, and thickness of this is compared with the normal tubular basement membrane. It should be thinner or equal to the tubular basement membrane. Anything thicker than that would be thick basement membrane, right? Then this whole round thing is the Bowman's space, and it is bound by this membrane which we call Bowman's capsule. The space inside is called Bowman's space. Within this, a tuft of capillaries, the glomerulus would be there, held at the point of hilum. Okay. So since these are capillaries, they are bound to have endothelium. So on the inner side, these cells are endothelial cells. Now, this is something normal. And on the outer side, as you see on the outer aspect, these very small cells are podocytes. So we'll see situations where these cells will become more prominent, and that is the pathological situation. Normally, podocyte would be something like this, very innocuous, small, sitting on the outer side. This is a Masson trichome stain where same thing is being depicted, and here you get little blue color here. This is a silver stain. For kidneys, we use Jones stain, silver methanamine stain, which stains the basement membrane and mesangium as black color. Normally, we should have a single thin line like this, like you draw with a pencil. Podocytes on the outside, endothelial cells on the inside. This is the endocapillary space. So when we will talk of endocapillary proliferation, it will be this area which I'll be telling that this area bound by this capillary is going to have more than one nucleus. So as you see, normally we are seeing only one nucleus. If there's anything more than that, that would be endocapillary hypercellularity. So this is the area where we will talk about endocapillary hypercellularity. And as I mentioned, this area is mesangium. So mesangial hypercellularity would be it will be a pathology restricted to this area. Since it is restricted to this area, so we expect that capillary should be normal and patent. That is how we are going to distinguish between an endocapillary proliferation or a mesangial proliferation, right? Then coming to tubules.
Dr. Ritambra, can I request you to change your pointer to a laser pointer? That
Okay,
makes it easier for us to see.
okay, I'll just try how to do it.
Go in the PowerPoint, on the left, further left, there is a pencil icon.
Yeah, this one.
Yeah, laser pointer.
Laser point, right?
Good. Thank you.
Thank you, sir. So coming to the tubular interstitial compartment, these are the tubules. As you see, these tubules are just back to back. There's hardly any space in them, and this is what a normal kidney interstitium should be like. There is a space. Normally, we don't see any interstitium, and tubules are back to back. Within these tubules, the ones which have more amount of cytoplasm are proximal tubules, and these ones which have a lesser amount of cytoplasm and nucleus is relatively big, or what we call in pathology terms is high nucleocytoplasmic ratio. These are the distal tubules. The proximal tubules, distal tubules, hardly any interstitium. This is normal, and proximal tubules are the ones which are more prone to ischemia. Then the fourth element in a kidney biopsy is arteries or arterioles. Here, this is normal because in an artery you will have internal elastic lamina, an endothelium, media, and adventitia. Arteriole will be smaller. There will not be any internal elastic lamina, muscle layer, and only limited amount of interstitium and a smaller caliber. So these are four normal components of a kidney biopsy. Pathology could be restricted to any, but sometimes the dominant pathology may be in one segment with secondary involvement of another segment, like glomerular pathology can have an element of tubular interstitial disease or a vascular disease. Similarly, whenever there is a vascular pathology, there is bound to be some damage to the glomeruli. So that we decide on the first slope or look, like which is the dominant region of pathology, and rest are taken as secondary pathologies. So coming to immunofluorescence, in immunofluorescence we look at both glomeruli and tubules. When we don't see any this kind of a green color within the glomerulus, that is negative stain. And this is an electron microscopic picture of a glomerulus. Just to orient you people, this is the capillary loop. It covers the mesangial area, which is this. It goes like this, and it is kind of a continuous layer, as you see. I can move from one capillary to another. So this is a glomerular capillary. On the inner side, what you are seeing are the endothelial cell. It has some holes, what we call fenestrations. On outer side, these cells are supported by these cells, what we call podocytes. And you must have heard of podocyte effacement. So these are the foot processes. They are supposed to be only this much thin. and they are closely placed. And this bigger cell is the podocyte's body. Processes which rest on the glomerular capillaries, and one podocyte caters to multiple capillary loops, as you see. So one damaged podocyte would affect three capillary loops. See, so that is how the dynamics of glomerulus are affected by damage to one component or the other. And endothelium and podocytes, they support each other's life and their maintenance. So damage to one structure is bound to affect each other. So podocytic injury will have some element of endothelial damage, and similarly endothelial damage would affect podocytes in one way or the other. Now coming to the kidney biopsy, how we divide our tissue into different these tissues for different kind of investigations. So kidney biopsy, as you see, generally we expect two cores, and we divide it like this, that from one core, this side we'll keep for light microscopy, immunofluorescence, and from each end we try to take core for EM, and from other core we'll do the same thing, so that we have equal distribution and chances of having medulla and cortex in each of immunofluorescence and EM fragment also. Just for the sake of information, that in case by chance you are able to take only one core, then the best way would be to put it for immunofluorescence, because after having done immunofluorescence I can use the same tissue for light microscopy, and from that I can even process electron microscopy. Fine. So single tissue, please put it always for immunofluorescence, because doing immunofluorescence on fixed tissue for light microscopy is not a good yield. So we always prefer to have single immunofluorescence tissue. So how these tissues should be sent? Light microscopic tissue should be sent in 10% buffered formalin. For immunofluorescence, we like to have it in Michel's media, which is not a fixative, it's a transmute media. It has a certain composition of phosphates and being there, which coagulates the protein in the state so that they don't lose their antigens. And after washing that media, we get the kidney biopsy into the same original position. So advantage of this Michel's media is that you can keep the biopsy at room temperature for at least 1 week. That means if you have a referral center, if you are going to have send biopsies to one central some laboratory where immunofluorescence is available, this works very well, because then you are able to transport it across the different
Where
centers.
the
Yeah.
envelope?
Hello. And this Michel's media is commercially available, and it can be made in your lab also. Both ways it's okay. For electron microscopy, we put the tissue in 2.5 to 3% glutaraldehyde. It's a milder fixative. Another way of doing it would be you just put it in formalin for briefly, look at your immunofluorescence. If you think that this tissue would need EM, next day you can put it in glutaraldehyde. This is practical way of doing. Some of the labs do it this way. Now coming to how we process it. So after having processed, these kidney biopsies are really cut at uh, 3 micron sections. This is thinner than our usual sections, which are generally 4 to 5 microns. These three stains are minimal. PS is must, then silver stain and Mason's trichrome, along with hematoxylin and eosin stain. This one we use only for looking for inclusions or for identifying the type of inflammatory cells, but the most useful stain is PS and silver stain. All the sections should be cut at multiple levels, as I'll just mention why we need to see at multiple levels. And first we look at glomeruli, tubules, interstitium, and arteries that I've already mentioned.
Dr. Ritambra, can I, yeah, maybe you can explain with this. What is a section?
Okay, so we saw the kidney biopsy. So each kidney biopsy is from a paraffin block. It is taken on a glass slide. So this is a slide on which one kidney biopsy has been cut at multiple levels, like 5 levels of same kidney biopsy are put on this slide, another 6 on this. And as you see, this increases the chances of picking up focal lesions, lesions which are limited to one area or the other area. If I didn't take this section, I'm going to miss if I had done only 3 sections. So see, the number of the chances of picking up any smaller lesions increases by doing these kind of sections. It's the same kidney biopsy from here to here, but cut at multiple levels and examined at all the levels. Fine. And all labs have some kind of a protocol that you'll have one HNE, PAs, Masson's, congruent, again a repetition of same stains so that we don't miss out on any of the segmental lesions, right? Then question is, how many glomeruli you would like to see before giving any diagnosis? Answer to this is variable depending upon the situation. Like if it depends, like if I sample only 10 glomeruli, chances of missing a focal lesion would be 35%. Whereas if I happen to see 25 glomeruli, chances of missing a focal lesion would be only 0.5%. So the more you see, the better it would be for not missing any focal lesion. And these, can you see these rounded black dots, the circles? These are the glomeruli. So if I want to see all the glomeruli, I need to have these many sections are seen at different points. The rounded thing are glomeruli, and these rest of the thing is tubules, and one blood vessel is seen here. These are different kind of stains. I shall show you examples and then talk about it. Now coming to what are the terminologies which we used. Like I just used a word focal. When do we use word focal is focal means total number of glomeruli and out of which how many are involved. So focal would be if less than 50% of the glomeruli are involved out of all those round circles. If less than 50% are involved, I will call it focal lesion. If more than 50%, it's a diffuse lesion. But out of one glomerulus, whether a part of it is involved or entire tuft is involved, that is how you will term them as segmental or global, right? Then to call it mesangial hypercellularity, as I mentioned, more than 4 nuclei in that mesangial region is what we call mesangial hypercellularity. And endocapillary hypercellularity is when you have increased number of cells within the glomerular capillary membrane. These cells could be anything. It could be leukocytes, endothelial cells, or mesangial cells. I'll show you some examples. Extracapillary proliferation is anything which is seen within the Bowman's space. And that extracapillary proliferation is also known as crescents, and we have different definitions of that. Fibrinoid necrosis is when you see the glomerular tuft replaced by fibrinous material. It's the fibrillar material. It has different staining characteristics. Same fibrinoid necrosis over the time will become sclerotic, and it will have some paler and hyaline look, which we call sclerosis. And lobular is something which I'll show you when I show you some examples. So focal and diffuse lesions. So let's see. In this, if I count these glomeruli, and if only 2 glomeruli are affected, I will call this is a focal disease. If all the glomeruli are more than 50% of the glomeruli are involved, I'll say it's a diffuse disease. Global is something when whole of the tuft is involved. If only segment of it is involved, it is segmental disease. Is that right? Okay. Then mesangial hypercellularity. I mentioned to you that this pink thing is mesangium. If there are more than 4 nuclei here, that is mesangial hypercellularity. And depending upon the number of increased nuclei in this mesangial region, we will grade it as mild, moderate, and severe. Please make note, in mesangial hypercellularity, these capillary lumina are free. They are white. There are no cells here. So that is what mesangial hypercellularity would be. However, when I say endocapillary hypercellularity, it is that white capillary space which is occupied by these cells. This region is occupied by different kind of cells, whether it could be only endothelial, It could be a mixture of neutrophils and endothelial cells, or it could be predominantly neutrophils. So what I'm again trying to indicate here is that type of cells will also matter in my final interpretation. Now coming to capillary walls. So as I told you, we always keep an eye on capillary thickness, because thickening of capillary walls means something is abnormal. So this thickness could be just because the matrix is increased, or it could be because mesangial cells interpose and a new membrane is formed. So you must have heard of double contouring or a tram track. So as you see my laser, here you see there are two black layers, outer and inner, and in between you are seeing some pink material. So this is double contour. This is tram tracking, and this means that this is a chronic process and it has been there for some time. That is why the body has taken time to put up another layer within the original outer layer. So this indicates that it's a chronic process, less likely to revert as compared to a basement membrane thickening, where there would be only thickened basement membrane because of immune deposits. Now, I mentioned about lobular pattern or MPGN pattern or membranoproliferative pattern. So it has two words, membranoproliferative, lobular. So lobule may mean this, these are the lobules of capillaries. So when these lobules are very prominent, we call it lobular accentuation. And why membranoproliferative? Because your membranes are thickened and there is endocapillary proliferation. So endocapillary proliferation with abnormal membranes are membranoproliferative pattern. At later stages, the endocapillary proliferation may subside and there would be increase in matrix like we are seeing here. So here we are calling mesangio-capillary pattern could also be a term. So this region is more like a mesangio-capillary, whereas this area is more like membranoproliferative, because here we are seeing increased number of cells also as well as abnormal membranes. In this part, matrix is increased and membranes are abnormal. Okay. Now, another term we used was extracapillary hypercellularity, also known as crescents. So, anything which is within the Bowman spaces, crescent, it could be a global, it could be segmental, and depending upon its composition, we classify them into cellular or fibrocellular or sclerotic. But whenever we are talking of crescent, we are meaning this space, a space which is Bowman space, which normally should be empty like this, but here it is occupied by different kind of cells. This is a fibrocellular because it has some amount of this blue matrix. This one is fibrous because here cells are very less. So if the matrix is up to 80% of the whole composition, it is fibrous crescent. If it is in between, it is fibrocellular. And cellular crescent is when more than 80% of this proliferation is composed of cells rather than matrix, right?
So when
Okay.
do you, Dr. Ritambra, you said cells. So
Yeah.
how do you say that whether there are cells or no cells?
So we say cells or not cells because this is a matrix, and you don't see any nuclei here. So this is just a matrix. Once you see these nuclei, that is of a cell, and as you see here, these are they have boundaries. Here it's only matrix. So a cell would have a boundary, it would have a nucleus, and when it kind of settles down, only fibroblasts are left out. So this nucleus is a fibroblast because it does not have any outline, and it is laying out this matrix. That is why it's a fibrous lesion or a fibrous crescent. Same thing would apply to this sclerosis also. See, now I'm trying to come to a fibrinoid necrosis. Why? Because this was normal. And this area is now replaced by something pinkish, some pinkish, and it is a little fibrillar in nature. Same thing after a few weeks, almost about 3 weeks we take, this converts into this kind of area where you don't see any nuclei. It is not this kind of a fibrillar, and it's trying to get sclerotic. Anything which is sclerosis would be paler like this. So sclerosis means the matrix becomes pale. instead of being very pink in color. So this is a transition from necrosis to sclerosis.
Can you also, Dr. Ritambra, describe which cells are best for, which stains are best for what lesions? For example,
Yeah.
which stain is best for identifying a crescent or characterizing a crescent? Similarly, for sclerosis, for fibrinoid necrosis, etc.
Right. So as you see in HNE, you get some clue that this is some necrosis, but best way to identify would be to do this special stain for fibrin, what we call Marshall scarlet blue, where fibrin takes up this very red color. Now, when we want to see sclerosis, we will like to see Mason's trichrome stain, and I'll show you it somewhere here. One second. Mm. So this is Mason's trichrome stain. So a sclerotic lesion tends to have this blue color. This blue color means sclerosis, whereas in HNE stain it will be a pale color and not very pink color. This is this black color. Whenever you see black color in a kidney biopsy, that means that's a silver stain. Silver stain always has a counter stain. So counter stain, different labs use different counter stains. And in this case, it is hematoxylin and eosin stain. That's why it is almost resembling an HNE stain. Like uh, this one is an HNE stain. So in HNE stain, you have this color of blue and pink, and in silver stains, many labs tend to use HNE as counterpart because it gives you an idea about the cells also, what kind of cells are there. So that's why some people prefer to use HNE as counter stain. This is the color of hematoxylin and eosin stain, and the black color, whatever you are seeing in any slide, is silver stain. The green color comes from Mason's. You see this area is pink, but this pink is different from this pink. It is very deep and fibrillar. So this is necrosis. These cells which have this kind of a lobated nucleus is neutrophil. The ones which are these round dots are lymphocytes. So that is how a pathologist kind of differentiates between different kind of cells.
Madam, do you stain them sequentially or like you mix them up, or like how do you do that?
We have an algorithm, like first slide would be stained by HNE, second by PS, third by Mason's, and fourth by silver, so that each kidney biopsy has been stained with all the colors. Marshall scarlet blue is not a routine stain. That only once we suspect, we would do that to confirm it. Some depending upon whether you are not sure on HNE that it is necrosis, then one would use. Otherwise, you can go on by HNE also.
If you want to use a counter stain, you stain it after the first stain, or like
Yeah. Counter stain is always after the first stain because that is just to give you a different color background.
yeah, that's better.
Yeah, see, like if PS, in PS stain, this is the actual color of PS, which is magenta. If I don't do a counter stain by hematoxylin, these areas are going to be absolutely blank. So you won't be able to kind of make out which area is tubular area, which is your capsular area. So this background counter stain gives you idea of the background. So that's why all stains would have some kind of a background stain. This area is necrosis, and this is Marshall scarlet blue to stain this fibrin. Now coming to patterns of injury. So are we going on a okay pace, or should I increase or decrease my pace?
What do you think, Onu and other colleagues? Is it okay? Are you following what Dr.
We are following, but if it is slower, it will be better.
Okay, I'll go a little slow. Fine. So, is everything clear by now, or you want me to explain something again?
Yeah, maybe we can stop and invite questions.
Yeah.
Onu and other colleagues, any questions on what Professor Nada described so far?
Chidimma, can you ask your question?
I don't have any question yet, ma'am.
Okay.
Okay.
Okay. So if there are no questions, I'll proceed, but you can still stop me anywhere if any question pops up in your mind. Fine. So when we examine a kidney biopsy, we first look at the what is the pathology like, what is the pattern of injury. So first pattern, which one of the patterns I would say is that you are seeing absolutely normal glomerulus. We saw these pictures earlier also. So this is a normal glomerulus. So even this normal glomerulus would mean some kind of pathology in a given setting. But here again, it would be important to have the clinical scenario. A normal glomerulus with could mean no glomerular disease, or it could mean a disease where there are supposed to be no light microscopic findings, like minimal change disease. Or if patient has hematuria and I find normal glomerulus, my interpretation or my thinking would be it could be a thin basement membrane disease. I need to do a EM. But with this morphology, if my patient had a nephrotic syndrome and my eye immunofluorescence was negative, I'll be okay. Possibly this is a podocytopathy with a minimal change disease morphology, right? Similarly, this normal glomerulus in a setting of a lupus could still mean a class 1 lupus nephritis, right? A normal glomerulus, when I see immunofluorescence, if it shows me some immunofluorescence positive with C1q, my diagnosis will change it to C1q nephropathy or C3 nephropathy. So never ever we go only by morphology. We have to take help of immunofluorescence, but you can have scenarios where our glomerular morphology would be absolutely normal. Another morphological change which we see in glomeruli would be that you just have thickened basement membranes without any hypercellularity. This kind of scenario would be, as most of you must be knowing, could be membranous glomerulonephritis, or a basement membrane thickening could also be a morphological expression of amyloidosis. But a special stain would help me, like in PS, the amyloid would be PS negative, whereas the membranous would be PS positive. Similarly, there could be segmental lesions. This is whole glomerulus and part of it is solid. At some stage it is having only matrix. So this is a segmental sclerosis, segmental of the whole glomerulus. So this could be a segmental sclerosis, and depending upon how many glomeruli are involved, it could be a focal segmental sclerosis or it could be a diffuse segmental sclerosis. But generally, as you know, most of the times the entities are focal and segmental glomerular sclerosis. This segmental sclerosis could also be a sclerotic phase of a necrotic lesion. So in that context, the clinical scenario would be important. If the patient is not nephrotic, then this segmental sclerosis may mean a necrosis which has healed, right? So everything depends upon the clinical scenario. So this is just to recapitulate that with a normal cellular glomerulus, we can have different scenarios. A perfectly normal membrane, it would mean minimal change disease or something like thin basement membrane disease, or could be a part of Alport syndrome. If you are having segmental sclerosis, it could be FSGS, focal segmental glomerulonephritis, which has healed, or it still could be Alport's. If you are having basement membrane thickening, then it could be diabetes, it could be membranous amyloidosis, and certain other conditions which we shall come to later on. If there is only basement membrane thickening, then it could be only membranous, it could be different kind of glomerulonephritis, which we shall talk about. But all this distinction between these would depend upon morphology as well as immunofluorescence. I may not be able to distinguish between a diabetic and membranous if I don't do immunofluorescence. I'll show you examples of this. Then Another pattern of injury I talked to you about was about when we have hypercellularity, either within the mesangium or within the capillary, when we call endocapillary hypercellularity. And there are so many causes. And again, way of distinguishing them would be immunofluorescence. So immunofluorescence will help me distinguish between a DPGN of infective kind versus an MPGN pattern which occurs in an immune setting or a lupus, something like that. So I'll talk about those patterns in a while. As you see, this panel is showing us different kind of proliferation. This one is
Kidney.
meeting record So what we are seeing here is mesangial proliferation. Why I said mesangium? Because endocapillary areas are normal. You see clear spaces here. This is endocapillary proliferation because here this area is being occupied by cells. We have cells here. So this is endocapillary proliferation. Similarly, this is also endocapillary proliferation, but here I've used another adjective, exudative. When we say exudative, when this endocapillary hypercellularity is contributed by lots of neutrophils. So that there are some clues in this kind of cells. So exudative endocapillary hypercellularity would mean something like DPGN, though even C3 glomerulopathy can have same pattern. But the type of cells also help us to fine tune our diagnosis. Similarly, this is an MPGN pattern. Why I'm saying MPGN? We always look for this reduplicated membranes. These split membranes along with endocapillary hypercellularity, because this again means a relatively chronic process as compared to this DPGN or exudative proliferative lesions. This is likely to revert. This is unlikely to revert. So that is why we try to make this distinction, right? Another point which we try to make a note when we are interpreting is whether our glomerular morphology is same in all the glomeruli or they are differing in different glomeruli in the same biopsy, because that is also a clue. When we have different kind of morphology in the same biopsy, that is a clue towards lupus nephritis. Even if by the time the biopsy is done, the workup has not been complete, we can suggest, we are sometimes able to suggest that this patient could be having a lupus nephritis based on pleomorphism or different patterns of injury in the same glomerulus. So this I think we have already done. I can go a little fast here. And now just to repeat that this is an MPGN pattern. This is also a lobular pattern. These are examples of lobular accentuation or a nodular diseases. So when you have abnormal and reduplicated membrane, it is termed as MPGN pattern. Diabetes also has nodules, but here the basement membrane is diffuse thickening. So what is the difference between these two? The difference is here the membranes are going to be reduplicated, whereas here the membrane is going to be diffusely thickened. There's no reduplication. The same matrix is here and it increases in amount in this central area, giving rise to a KW nodule or what we call diabetic nodule. So though overtly both are looking lobular accentuation or nodular patterns, but based upon kind of basement membrane thickness, the diseases are going to be different. Similarly, lower panel, it is again a nodular lesion, but here the kind of thickness is pale. It's not magenta pink. So this is what a amyloidosis would look like. Similarly, in monoclonal diseases, we tend to have nodules which are almost similar to your diabetic nodules. They also have diffuse basement membrane thickening. But the clue we take from morphology is multiple number of nodules as compared to a single nodule. So if I find single, I'm kind of my diagnostics will shift towards diabetes. If I have multiple nodules, my thinking would tilt towards monoclonal disease. But again, obviously, we will confirm by immunofluorescence. So extra capillary proliferation we have already done. And we know that extracapillary proliferation we tend to see in small vessel vasculitis related glomerular pathology. And this I think we shall cover later on. Let's just first complete the morphological details. So let me come to the immunofluorescent patterns, some of them. So as I was mentioned earlier, that while interpreting biopsy, we tend to give you some prognostic features also, like number of glomeruli having necrosis, crescents indicates that these are active lesions. If there is edema in the biopsy or inflammation in the biopsy, that again indicates that these are active lesions. These, when become chronic, result in interstitial fibrosis. A cellular crescent will become fibrous crescent. A necrosis or proliferation would turn into glomerular sclerosis. So, if a biopsy shows us more of these lesions, that indicates that reversal is less likely. So, those biopsies tend to look this kind of blue as compared to lesser blue in the lower panel. So different stains give us different clues, and we have some way of telling that this biopsy is having more active lesions versus more chronic lesions, or similar kind of lesions. Now, maybe some clues towards interpretation of immunofluorescence. Do we want to have some questions, Anu, till this point, or shall I proceed with immunofluorescence?
I think, is anybody, I don't know if anyone has any question.
Okay, so shall I proceed?
Yes,
Okay.
ma'am.
Okay. So we've seen what patterns, we've seen that different patterns have different etiologies. So come to those etiologies, we take help of immunofluorescence, right? And in immunofluorescence, I already mentioned, we use transport media, that is Michel's, and a normal panel, a routine panel, is comprising of 3 immunoglobulins, GAM, 2 complements, C3 and C1q, both the light chains kappa and lambda, and fibrinogen if you want to pick up a necrosis. Though on morphology also you can do that. Then when we are interpreting, we try to look at the pattern of immunofluorescence. It could be granular, linear, or negative. Posse immune is when anything less than 2 scale of 2 plus of on a scale of 0 to 4. We interpret our immunofluorescence on a scale of either 0 or 4 depending upon the intensity, which I shall just show you some examples. So we are noting the pattern, we are noting their intensity, and we are noting their location. Location within the glomerulus and location outside the glomerulus. Within the glomerulus, whether it's in the mesangium, in the capillary, or in the lumen. Outside the glomerulus is whether it's present in the capsule, tubular basement membrane, or the blood vessels. Okay, so let's see some examples. So this is immunofluorescence with IgG. I don't see any significant positivity. So this is negative for IgG. So this is how my glomeruli are going to look. They don't light up with anything. Then here what I'm seeing is my stain is IgA. This pattern is granular and it is located to mesangium. Why I'm saying mesangium? Because you can see this negative membranes. Can you see these negative membranes? So since they are only localized to mesangial area and it is in IgA, and it is very bright, even at 10x, I'll be able to pick up this positivity. So I shall say 4 plus mesangial IgA granular deposits, right? Now, this is IgG immunostain, and I see positivity along the basement membranes. Unlike the previous slide where it was only in the mesangium, here I'm seeing along the basement membranes. Intensity is less than that because I'm still able to discern the pattern. So it's 3 plus granular positivity along the glomerular capillary loops with an immunofluorescence with IgG antibody, right? This is what we see in membranous. Here again, now this is C3. C3 stain, a granular deposits. It's very hodgepodge, both in the mesangium and capillaries, very coarse deposits. So these are 3+ to 4+ mesangial and membrane granular deposits of C3. Now, it's not only one deposit which matters, it also depends what are the combinations. If it is only C3, then my diagnosis would be C3 glomerulopathy. If I have IgG with C3, so my diagnosis would be immune complex mediated glomerular disease, right? So it's not only one stain, but it's the combination of immunoglobulins and complements also decide what kind of disease we are going to label it finally. The third pattern is linear pattern with IgG along the capillary loops. Linear means as if you have taken a sketch pen and you are drawing like this. It's absolutely straight. There are no dots to it. Whereas if I take you to the membranous pattern, there were these kind of little dots here, which are present on along the capillaries. But if I come to linear pattern, it's just a straight line. So this linear pattern would mean anti-GBM disease, whereas that was also along membrane, but that meant membranous. So what I'm trying to convey is the pattern of immunofluorescence makes a whole lot of difference. Same immunoglobulin in a linear pattern makes it anti-GBM disease. If it were in the form of granules, it makes it membranous. And if I have no IgG, only C3, my diagnosis changes to C3 glomerulopathy. Another thing, this is what I was trying to tell you, that if I have combination of IgG, C3, it is immune mediated disease. In isolation, C3 is C3 glomerulopathy. If I have IgG and IgA both, then it could be either immune mediated disease or it could be IgA dominant, IgA nephropathy, right? And pattern, this is linear, this is granular. This is granular, this is granular. So you can make out the difference of patterns here. When you have everything we mean G and A, both the complements, then it is full house pattern, which you see in lupus. Now, presence of immunofluorescence outside glomerulus also had importance. Like you are seeing IgG along tubular basement membrane. So this again indicates lupus to us. Then I mentioned about light chains. If kappa and lambda are almost equal, or maybe 3 and 2+ intensity, that is polyclonal disease. But if it tends to be only on the one side, like kappa is positive, lambda is negative. So this is monoclonal with kappa restriction. Similarly, in cast, we also see kappa positive, lambda negative. So this is monoclonal cast, right? So light chains have a very important role in deciding what kind of pathology it is, and you all know that it has a very important clinical bearing and a diagnostic and therapeutic bearing. Electron microscopy is important. Maybe it depends upon your resources. If available, we should always do. But if not available, then at least we should try to do in situations where it is absolutely necessary, like situations of Alport's disease and thin basement membrane disease. So just for a comparison's sake, just to give you a visual idea, this is a normal glomerular basement membrane. These are the podocytes and this is endothelium. A patient who had hematuria or who had FSGS like morphological features, one could label it as FSGS. But when we do EM, what you see, instead of a uniform membrane like this, I see laminations here. I see the outer side is kind of scalloped. It has some mountain-like things on the outer side. It has these holes. So these kind of morphological changes in a case which is immunofluorescence negative and not responding to your classical treatment for FSGS, one could suggest that this probably was an Alport's disease. Similarly, your patient had hematuric presentation. Morphology was normal, immunofluorescence was negative. So whether that was a glomerular hematuria or whether it was from any extraglomerular site, you do EM and you find these membranes are very thin. So you could tell that this hematuria is possibly of glomerular origin, and then needs to be confirmed by if you have facilities for molecular pathology or there are some kind of immunofluorescence available for Alport's disease. So that is how, like, there are certain situations where EM is kind of very useful and diagnostic, like this. As you see, this is a normal electron density of basal membranes or a mesangium. But if you have something which is very dark, almost charcoal, very dark, this is what a dense deposit disease looks like. So here EM would definitely help you. Then locations of EM we try to use for classifying our diseases. I think for first class, I won't like to go too much in detail. I'll just try to wrap up. Like, these are the situations where EM will kind of help you out, differentiating between different kind of these kind of what we call organized deposits, like whether it's amyloid or fibrillary or immunotectoid. So EM has some kind of differentiating features depending on size and their shapes and all. So EM has some role, but if you don't have, we won't say that it is mandatory, but it can help you. So coming back to our first scenario, that we have all these syndromes and we have all these patterns, they fit into each other depending upon immunofluorescence pattern and their morphological patterns, and that is how we try to make the diagnosis. So shall we stop here, or shall we continue?
So I think it's been fascinating. It's quite quite a lot of information. I'm sure that our colleagues are digesting all this information, and we might just stop here and invite questions if there are any at this point. Any questions, Onu and other colleagues?
You can have asked any question, simple, complex, whatever type, like, don't hesitate. It's a very basic class.
Sorry, Ma. Good afternoon, Ma.
Good afternoon.
Good afternoon. Okay. Thank you so much for the lecture. Please, Ma, I would want to ask how concerning the immunofluorescence, how do you differentiate between IgA, IgG? You know, I'm always finding it difficult. Does it have to do with the patterns that you see there, or is just that you're aware that you're staining for those antibodies? I don't know whether you get what I'm trying to say, Ma.
There are, like, when we stain, let me take you to slides somewhere. Just a second, I'll come to my slide. See, just for a second, I'll tell you, these are slides, right? But these are stained by HNE, PA, Masons, and different stains are written here. So this is for light microscopy. But for immunofluorescence, what will happen is, one slide we will put IgG, another slide we will put antibody of IgA, third slide we will put antibody of IgM, then C3, C1q, kappa, lambda, and fibrinogen. So different slides will have different antibodies poured on that, right? So after staining them for 1 hour, we will see them different slides under immunofluorescence microscope. So if this slide shows us immunofluorescence green color, this is IgG positive. IgA, it doesn't show me any green color, this is negative. So in that scenario, my disease will become IgG driven disease or IgG positive disease. If suppose when I stain and when I'm looking at the slides, IgG was negative, this slide did not have any green color. Second slide, which was IgA, had green color in the glomerulus, and IgM also didn't have any any green color. So since I had green color only in IgA, so that will make it IgA disease. Am I clear? Does it answer your question?
Yes, it does. Thank you very much.
Yeah, because same tissue is cut at different levels and put on different slides. and different antibody, each antibody on one slide. So either it's positive or negative, right? And that is how we'll in the end sum up. Suppose it is IgA positive, C3 positive, and kappa and lambda positive. So I will say it is an IgA disease with C3 and both light chains being positive. Fine?
Great. Wonderful. Thank
Yes,
you.
ma. Thank you.
Most welcome. Any other?
Please, Mike, can you also throw more light on when you say is endocapillary proliferation versus mesangium?
Sure.
And then when you have subendothelial versus membranous deposits.
Okay. Yeah. So see, this is the glomerulus, है ना? So in mesangial proliferation, the number of nuclei only in this central pink material are more than 4. Normally up to 3 nuclei I want to see. For example, this region has only 3 nuclei. So if all were like this was normal. But here we see 5-6 nuclei in this pink region. But capillary, this is empty. There are no cells here. So this is mesangial proliferation. Right? Part is normal. Why normal? Because our capillaries are absolutely empty. There are no cells here. But if I come to this region, here, this part is also normal because here I'm not seeing any cells here. In this capillary lesion area, which is bound by a capillary membrane, doesn't have any increased number of cells. But if I come to this area, this black color is membrane. So it has having so many cells. There are about 10 cells. So this is endocapillary proliferation. So here again, this is endocapillary proliferation. And subendothelial we mean when this is the membrane. If anything is underneath this side, that is subendothelial. It is smooth on the outer side. So that makes it subendothelial. So here the deposits are subendothelial and there is tram tracking or reduplication of basement membrane. You can see 2 black lines. This kind of a thing would be subendothelial deposit only. But once you have 2 lines, that becomes tram track or what you call basement membrane reduplication, right? So for mesangial and endocapillary, these are 2 examples. Like, or maybe you can compare these 2 also. This region has to be populated to call it endocapillary. The central, the one which is bound by this capillary basement membrane.
Thank you, Dr. Ritambra. Is that clear, Onu?
Yes, it's very clear. Thank you very much, ma'am.
Most welcome.
Any other last minute questions? I know we have been going for more than an hour.
Madam, I think one thing, I think these are all in the exudative picture. I think these are all neutrophils in the Bowman space, right?
Yeah.
This is something which everybody can see and interpret like.
Yeah. Neutrophil, Dr. Raja said neutrophil because you see multiple lobes of nuclei. Lymphocyte will have just 1 dot. It will be something like this. Whereas here you can see it has multiple lobes and it's in the Bowman space. And their presence in Bowman space is an indication that this is going, the basement membrane must have ruptured somewhere and they have come as a response, and soon there is going to be a crescent here. Because crescent always happens whenever there is a break in basement membrane. So this would be an earliest clue to presence of an early crescent.
Great, thank you. Well, I think that's great, and Dr. Ritambra has answered most of the questions, and the silence seems to indicate that it has gone on very well. So I would like to draw this to a close by thanking Dr. Ritambra once again for doing this at a relatively short notice and at a late hour also. And we'll actually set up a series of these classes and schedule it properly so that the information can be circulated widely. And of course, Dr. Ritambra will also have time to prepare, not to prepare, I mean, she has everything prepared, but to schedule this in the middle of many other things that she's doing. So thank you.
Thank you, sir. Thank you for the opportunity.
Thank you all. Thanks. Bye.
Thank you. Thank you. Thank you. Bye. Bye.
Thank you. Thank you.
Bye.
Bye.